Hello everyone, welcome to Roadmap to Residency. I am Abhiraz, your coach for the Club 250 Matchmaker sessions. We will be running through a question with you guys to help you in your journey to 250. So whenever you encounter a USMLE style question, the first thing that you need to do is to read the last line first. Now this will give you an idea about what to look for in the long question stem. So here we have, what is the primary action of PTS contributing to this patient's condition. Okay, so a 50-year-old postmenopausal woman presents with a history of recurrent kidney stones and recent complaints of generalized bone pain and muscle weakness. On examination, she appears well nourished and her blood pressure is normal. Lab tests reveal hypercalcemia and hypophosphatemia. One concept that you need to remember for the rest of your lives is that whenever calcium comes in, phosphate has to go out, or phosphate has to go out to maintain the level of the calcium. So further assessment reveals that her PTS levels are significantly elevated. So what is the primary action of PTS in this patient? PTS reduces the phosphate reabsorption, increasing the blood calcium. PTS boosts bone resorption, lowering the calcium levels. PTS influences vitamin D, affecting the calcium and phosphate. PTS enhances the muscle glucose uptake and insulin sensitivity, or PTS controls the adrenal cortisol, affecting the calcium and phosphate balance. Please pause the video and think what is the answer. So the correct answer is A. So option A is correct because it accurately describes one of the primary actions of PTH in regulating the calcium and phosphate. Now, PTH is secreted by the parathyroid glands and play a crucial role in maintaining the normal calcium levels in the blood. One of its main function is to reduce the phosphate reabsorption in the renal tubules of the kidneys. This means that when PTH is released in response to the low blood calcium levels, it acts on the kidneys to decrease the reabsorption of phosphate, leading to the increased excretion of phosphate in the urine. Now, this reduction in phosphate reabsorption allows more phosphate to be excreted in the urine, preventing it from being reabsorbed into the bloodstream. As a result, the concentration of phosphate in the blood decreases. However, the decrease in phosphate levels is not the primary goal of the PTH secretion. Rather, it is a consequence of PTH efforts to increase the blood calcium levels by promoting the excretion of phosphate. Now, PTH indirectly helps to elevate the blood calcium levels as the inverse relationship between the calcium and phosphate is maintained. Now, this line just explains everything that I told you till now. So the inverse relationship between the calcium and phosphate. Whenever calcium comes in, phosphate has to go out. So option A is correct. Now let's talk something about the PTH and all. So the PTH activities, whenever there is whenever there is decreased ionized calcium or increased phosphate or decreased 125 vitamin D3, then there is the stimulation of the parathyroid gland, and then the PTH is released into the circulation. Now this acts on the renal tubular cells, which increases the vitamin D synthesis. There is increase in the reabsorption of calcium, and there is decrease in the reabsorption of the phosphate. So the urine calcium will decrease and the urine phosphate will increase. Now, please remember these 2 points, okay? Because the USMLE has this audacity of asking you the up-down arrows. So questions like this, the concepts like this are most frequently asked in the up-down arrows. So the ultimate effect is the increase in the calcium and decrease in the phosphate. Now, this is the action on the renal tubular cells. Now, the PTS also has action on the vitamin D activity. Now, it activates the vitamin D, and this vitamin D will act on the bone, which will increase the calcium and increase the phosphate released from bone. So, this will lead to the bone reabsorption, leading to the increased calcium and increased phosphate in the blood. Also, it acts on the intestine to increase the absorption of calcium and phosphate. So there is increased calcium and phosphate by its action on the vitamin D3. Now, the thing is that the main role of the PTH is to maintain or to increase the calcium level. So whenever there is increase in the calcium level, that will ultimately lead to the negative feedback mechanism in the parathyroid gland. Also, the increase in the vitamin D level will also have a negative feedback in the PTH synthesis. What are the functions of PTH? So increased free calcium in the blood, that is the primary function. Increased calcium and phosphate absorption in the GI system. Increased calcium and phosphate from the bone resorption. After that, there is increased calcium reabsorption from the DCT. You need to also remember the sites from where it is getting reabsorbed. Also, there is a decreased phosphate reabsorption in the PCT. Increased 125 calcitriol production by activating the 1-alpha hydroxylase in the PCT. So the important is this, and this. Let's talk about calcium homeostasis. Now, the primary calcium exists in three forms: the ionized or free form, bound to albumin, and bound to ions. So the ionized or the free calcium is the primary regulator of the PTH. Now, changes in the pH alter the PTH secretion, whereas changes in the albumin concentration do not. So whenever there is a decreased ionized or free calcium, that will cause the stimulation of the PTH or the stimulation of the parathyroid gland to release the PTH, and then the PTH will lead to the increase in the calcium levels that by the mechanism that we have discussed earlier. Now, also here, the thyroid gland releases calcitonin. This calcitonin will act on the bones and the kidneys. In the bones, it will stimulate the calcium deposition in the bone. So this will decrease the blood calcium level, and it will reduce the calcium uptake in the kidneys. So that will increase the excretion in the urine, and that will also decrease the blood calcium level. And now, whenever this mechanism leads to the decrease in the blood calcium level, then that will have a stimulus in the PTH gland. So the PTH gland will secrete the PTH, and then it will again increase the blood calcium level. Or whenever this mechanism causes the overactivation or the over increase in the blood calcium level, then again that will stimulate the calcitonin release. Okay, that will again manage the that will again lead to the normal. So this is how the calcium level is maintained normal by the interplay between the PTH and the calcitonin. Okay, remember calcitonin is secreted from the thyroid gland, not from the parathyroid gland. Okay, the ultimate effect of the parathyroid gland is to increase the calcium level. So PTH gland increases the calcium level, thyroid gland decreases the calcium level. Now, also, this is the same one, typically same figure. Okay, now let's talk about something about the calcitonin. This is the textromin first aid. So source is the parafollicular C cells of the thyroid, which decreases the bone resorption, increases the serum calcium, will lead to increased calcitonin secretion. So increased serum calcium will lead to increased calcitonin secretion, and the increased calcitonin will ultimately decrease the serum calcium. So calcitonin will lead to the decrease in the calcium level. Okay, if there is something that is increasing the calcium level, then there must be something that is decreasing the calcium level, right? That is how the homeostasis is maintained. So calcitonin, where we have written that, opposes the actions of PTH, not important in the normal calcium homeostasis. Calcitonin tones down the calcium level. Now, there is increased calcium, which will inhibit the osteoclast. If the osteoclast is inhibited, then there will be the decreased resorption of the calcium, and the calcium will be deposited in the bones only. So calcitonin lowers the serum calcium by inhibiting the osteoclastic bone resorption. Now, let's have a simple concept about bone remodeling. So the bone is continuously remodeled at discrete sites in the skeleton in order to maintain the integrity of the tissue. Now, during this process, the old bone is resolved by osteoclast, right, and replaced with new osteoid secreted by osteoblast. And this is the osteoid, okay? Here, this is the osteoid. First osteoclast is activated and the resorption phase takes place approximately 10 days. Following the resorption, unclassified macrophage-like cells, these ones. So after the resorption by the osteoclast, okay, number one, the unclassified macrophages come in action. That is number two, are found at the remodeling site in the intermediate or reversal phase. Now, osteoblast precursors are then recruited. Now, after that, osteoblast will be recruited. Number three, now, which proliferate and differentiate into the mature osteoblast before secreting the new bone matrix. Now, this is the new bone matrix. The matrix then mineralizes to generate the new bone, and this completes the remodeling process. Now, this is the simple thing. So, whenever there is injury or something, or whenever the bone needs to be recovered, then first osteoclast comes and eats the dead bone. Then macrophages comes in place. Then there is the immature osteoblast, which then transforms into the mature osteoblast. And these mature osteoblasts will form the osteoid and the new bone. Now, this is how the new bone is formed by the phase of quiescence, that is aging, resorption, reversal, formation, mineralization, and after that again quiescence, and again this will continue. Thank you for watching. We will again back in the next one with the next super duper concept.